The caruncular approach provides good access to the medial orbit posterior to the lacrimal sac fossa and to the orbital floor, for example for medial orbital wall decompression. The medial orbit has been infiltrated with local anesthetic with adrenaline. Traction sutures retract the upper and lower lid medially and superiorly and inferiorly respectively. The globe can also be adducted with a traction suture to expose the base of the caruncle. The conjunctiva is incised at the junction between the caruncle and the plica, although some surgeons prefer to excise into the lateral part of the caruncle itself. The incision is extended around 8 to 10 mm superiorly and inferiorly, such that it curves a little laterally to at least in line with the puncti. Predominantly blunt dissection is used to dissect towards the posterior lacrimal crest. This exposes Horner muscle. This muscle is the medial condensation of the orbicularis muscle and attaches to the posterior lacrimal crest just posterior to the posterior limb of the medial canthal tendon. The orbital septum can be seen as a white membrane immediately posterior to the Horner muscle. They are adherent, but if they can be separated during the approach to the medial orbital wall, the orbital fat can be restrained in the orbit for as long as the septum remains intact. However, usually some fat escapes, but can be retracted with malleable retractors and neuropathies. Alternatively, supramedial and inframedial orbital fat can be resected at this stage if orbital fat decompression is required as well. An arc-shaped incision is made in the periorbita at the posterior lacrimal crest. The periorbita is raised posteriorly to expose the medial orbital wall. The firm fan-like attachment of Lockwood's ligament is encountered at the inferior aspect of the crest, about midway between the medial canthal tendon above it and the opening of the nasolacrimal duct below it. Although not commonly seen, awareness of the anatomy of the individual patient's anterior and posterior ethmoidal arteries is very important, as they may be hanging on a mesentery more inferiorly than usual, in which case they should be clipped or cauterized. Management of the anterior ethmoidal artery can be seen in another video on this website.